Thank you for inviting me to participate in this prestigious meeting. Today I'm going to illustrate our experience in Dubai Hospital for getting the radial artery by the endoscope. As we all know that coronary artery bypass graft is a bread and butter of cardiac surgeons since its start by Reno Favallaro in 1967. In 1973, Carpentier started to use the radial artery, but the enthusiasm of using the radial artery started to become low because of the problems associated at that time with the use of the artery. Specifically, the artery goes into spasm and the graft will occlude. But currently, the radial artery gained new enthusiasm to be used as a second popular arterial conduit after the Lima. In Dubai Hospital, we started this technique since January 2020 by adopting the endoscope for harvesting the radial. To get this, we have a preoperative evaluation, we have intraoperative management, and we have a postoperative follow-up. The preoperative consideration for the patients by taking careful history and examination to avoid any cases of major trauma or contractions in the hand. But the most important factor is the artery should be virgin. It should not have been used by the cardiologist for doing the angio. If the angio is done through this arm, this is abandoned for at least 6 months. For the preoperative assessment as well, the most important is to have to check the circulation in the hand. And this is done by Allen's test, pulse oximetry, and Doppler evaluation for the radial artery and ulnar artery. Another important issue, you should not put the radial artery in a lesion of a coronary artery less than 85%. Otherwise, you will get definitely a graft occlusion. The intraoperative points, we are using the non-dominant hand, except few cases by agreement with the patient that we have used the dominant hand. And we have never used a bilateral radial artery, only unilateral in the non-dominant hand. We use the VasoView HemoPro system from Maquet. This is used to get the vein and the saphenous vein, and after the vein is finished, then we'll shift to get the radial artery. Intraoperatively, the hand of the patient should be at 90 degrees angle to the table or to the patient. And after the routine preparation, prepping and draping, then you start to milk the hand from distal to proximal to make sure that the hand is not having any more blood there. And then you have to apply the cuff. Before starting even the vein, a bolus of heparin should be used, 1,000 to 2,000 international units. And then you have to apply the tourniquet. The tourniquet is applied with around 75 to 100 millimeter mercury above the systolic pressure, but it should not exceed 250 millimeter of mercury. And the tourniquet time should never exceed an hour. We start by doing a small incision around 2 to 3 centimeter above the crease of the wrist. And we start the endoscopic dissection and the CO2 insufflation to around 10 to 12 millimeter mercury. The endoscope will be proceeded anteriorly first, then posteriorly, then you start dissection the lateral walls of the artery. I will not complete the video for the sake of the time.
Take pictures. Now this is the fasciotomy step.
In all cases, we do fasciotomy for the brachioradialis. The fasciotomy here will serve two purposes. You need to get a good view, and the second important issue is to avoid the occurrence of a compartment syndrome, just in case if a bleeding happened in the arm. So a fasciotomy is mandatory in all cases. Sorry. Then after that, we start securing the branches in the arm one by one by using the cautery, and then we'll get the vein out by making a small incision in the antecubital area, what we call stab and grab. And you get the graft out and you start doing the preparation. Usually we get the radial artery with the accompanying 2V committance. Try not to avoid touching the arteries to avoid spasm. And after you get the artery outside, then you start skeletonizing the artery completely, removing the fascia, and then securing the side branch by regular liga clips. We don't close the hand except after finishing the surgery and neutralizing the heparin by protamine, but you just cover it rapid by CREP bandage. At the end of the surgery, you make sure that there is no bleeding, and then you close the skin and subcutaneous tissue and apply a CREP bandage without much pressure. In the post-operative period and follow-up, all the patients should receive a calcium channel blocker. We adopt amlodipine 5 milligram for all our patients. Then we evaluate the patients for any neurological pains, any hematomas, any wound complication. The results, as I said, we have started in January 2020, and if you can see, 8% only of our cases that underwent CEBG in 2020. Then year after, the number became 16% of cases, 22, 38, and currently last year, the number of cases is around 62% of all patients undergoing CEBG in Dubai Hospital had an endoscopic radial artery harvesting. Our results here, the cohort of patients, the age usually are young patients, 49 years, median age. All of them, most of them are hypertensive, diabetic, and dyslipidemic. We have never did a conversion from endoscopic to open technique. We have never done a counter incision to try to control any bleeding in the arm, and no patient had required re-exploration for bleeding in the forearm. The operative findings, the mean length of the incision is around 2.2 centimeter. The mean length of the radial artery graft is around 18 centimeter. The median number of repair is 0, and median harvest time is around 25 minutes. We started by almost an hour, and now it's less than half an hour. This is because of the learning curve. You start in the beginning with lengthy procedure, then by time, when your hands get trained, then the harvesting time is less and less. The complications, we have not faced any major complications. Some hematomas, some color changes, no wound infection, and no vascular complication, and no major neurological problems. In conclusion, the Dubai Hospital experience in endoscopic radial artery harvesting started as early as 2020. The current consensus of most centers around the globe that endoscopic radial artery harvesting should be the technique of choice to get the radial conduit. And we recommend to adopt the endoscopic radial artery harvesting technique and to use the radial artery as a routine second favorable arterial conduit after the Lehman. Thank you very much.